around kind of 40, 45 minutes, then we'll have a bit of time for questions and answers at the end. So if you just want to pop any questions into the chat, if you have any as we're running through, that would be great. So as Devine said, thank you for joining us, especially on this such a hot day. I am very, very hot, so excuse my brain if it's a little bit slow. And as Devine mentioned, we'll be exploring how to turn evidence into decisions in the context of NHS integrated care boards. And my name's Nicola Chicken, as Devine said. Next slide, please, Devine. Thank you. So we'll start with some context around our roles and what's led to today's session. So between 2025 and 2026, NIHR Applied Research Collaborations appointed 71 knowledge mobilisation fellows across the country. We're embedded in ICBs, local authorities and universities. And as Devine mentioned, Juan, Tammy and I are the fellows within the Yorkshire and Humber Applied Research Collaborative, or ARC for short, embedded in our 3 Yorkshire and Humber ICBs. Our aims are to mobilise research evidence, encourage collaboration to inform decision making, and to tackle inequalities in the healthcare sector. Last year, we interviewed 15 senior leaders across Yorkshire and Humber ICBs, so Humber and North Yorkshire, West Yorkshire and South Yorkshire. And we wanted to discover their understanding of knowledge mobilisation, or KM for short. We'll probably use quite a few acronyms throughout this, so I'll try and explain them before we start using them. So knowledge mobilisation, or KM. Wanted to understand how they accessed and used evidence, their evidence preferences and formats, the barriers, challenges, and the opportunities for KM within ICBs and any support needed. So this session is a reflection of that, and it aims to help to respond to those identified needs. So we want to raise KM awareness and strengthen links between Yorkshire and Humber ICBs and Yorkshire and Humber ARC to share learnings across the region and use evidence to better inform the strategic commissioning processes that ICBs are mandated to lead. Next slide, please. So we've pulled out 7 key findings from the interviews that we undertook. So I'll just run through those briefly with you. So we found that understandings of knowledge mobilisation vary quite considerably, spanning academic life cycle models through to more operational NHS framings centred on insight, learning and decision support. In ICB context, the language of knowledge mobilisation is rarely used, with terms such as insight, evidence into practice, or knowledge to action resonating more strongly. ICBs mainly draw on national guidance, so for example, NICE, NHS England and government policy, as well as system intelligence, gathering evidence pragmatically through horizon scanning, clinical input, stakeholder insight and impact assessments, and with various awareness across the ICBs of ARC resources across teams. Decision makers value concise and authoritative evidence that supports commissioning, value for money and implementation. And while methodological rigour is respected, lengthy or non-actionable evidence can inhibit decision making. So in terms of barriers and challenges, so despite a strong commitment to evidence-informed decision-making, things such as delivery pressures, limited capacity, skills gaps, and structural constraints restrict consistent evidence use. Research can feel inaccessible or poorly aligned with operational realities, while financial pressures, political considerations, and siloed working further shape how evidence is applied. Opportunities that were identified include translator roles, multidisciplinary working, practical language, and closer alignment between evidence, innovation, and organisational change. Integrating knowledge mobilisation into commissioning and improvement cycles and addressing misalignments between research timelines and NHS decision-making timelines were seen as critical enablers. And in terms of support, interviewees called for insight partnering roles that combine technical expertise with strong relational skills to build capacity within the ICBs. So in response to the consideration around practical language, we were introduced today as strategic evidence partners. Our original role back when we did the interviews was we had two different titles, knowledge mobilization fellows or knowledge mobilization business partners. But we took the decision to move more to that strategic evidence partner language as that resonated more strongly with the colleagues that we're working with. And in terms of practical implementation, so effective knowledge mobilization requires active engagement, tailored training, user-friendly tools, and integration into routine organizational processes rather than passive dissemination. And while dashboards and reports are widely used, they're not always intuitive, and knowledge mobilization is rarely embedded as a standing agenda item in key forums. Next slide, please. Thank you. So the anticipated outcomes of today's session are to better understand where the ARC sits within health and social care infrastructure and how we can be useful in commissioning decisions within your local ICB context, to explore evidence that can help inform population needs, system pressures, and key commissioning priorities such as integrated neighbourhood health and population health, which we will come on to later in the session, to help connect existing evidence and data into clear, accessible outputs that support real-world decisions, and understand the role of knowledge mobilization in translating evidence into real-world impact. To help identify common barriers around evaluation, monitoring, and sharing evidence, and applying practical first steps to address them. And really to help develop strong links with the wider ARC applied research collaboration infrastructure and how we as strategic evidence partners can support decision making. Next slide, please. So we're now going to explore who the NIHR applied research collaborations are, what we do, and the themes that we focus on in Yorkshire and Humber. So NIHR is the National Institute for Health and Care Research, and applied research collaborations, or ARCs, are local partnerships designed to deliver applied health and care research that addresses the needs of local populations and health and care systems, while also aiming to be scalable across the country. There are currently 10 partnerships across England between NHS providers, universities, charities, local authorities, health innovation networks, and other organisations. You can see the list in the pink boxes on the slide. A Pan-London ARC is in the process of being commissioned. They're just working that through at the moment. So ARCs were announced, as you can see on the timeline, in July 2019 as part of a 5-year programme. So that's what we kind of refer to as ARC 1.0. There was an extension then until March 2026, so ARC 1.5 due to COVID-related reasons. And the current phase of ARCs started in April 2026 and runs for 5 years until March 2031. So that's what we kind of informally call ARC 2.0. And the knowledge mobilisation programme that Tammy, Juan and I sit within started in April 2025 and is currently funded until September 2027. Next slide, please. So this diagram aims to show where the ARCs sit within the wider NIHR research infrastructure. So the world of NIHR can be quite confusing and baffling. There's a lot of different organisations that sit within it. So hopefully this diagram shows you a little bit about where those different collaborations and centres sit along the kind of research journey. So as you can see, the ARCs focus on translation of research, knowledge and evidence into practice. So ARCs really sit at the interface between researchers, health and care organisations, policymakers and communities, helping ensure that research does address real world priorities and is actually used in practice. So this means that our research projects within the ARC are focused on implementation readiness, impact, practical application and mobilisation into the health and care system. And ARCs strive to be very much aware of the system context into which research knowledge is mobilised. We understand it's messy, it's complex, it's not always straightforward. So So our role as strategic evidence partners is key to this, bringing insights from our ICBs to our research teams to ensure that research does address local priorities. Next slide, please. Thank you. So then bringing it down to Yorkshire and Humber Arc level, so there are 4 research themes, each led by and consisting of theme experts. So we have healthy families, health and care in our ageing society, mental health, and delivering care closer to home. And we also have 2 cross-cutting themes, which is system-level economic evaluation modelling, or STEAM for short. We've shortened it, as you can tell, it's a bit of a mouthful, and data, AI, and visualization. So these themes, as well as involvement and collaboration with the public and system partners, help to guide our teams to deliver research that really makes a difference. Supporting across these themes, you can see in the pink boxes are the research inclusion team, research capacity development team, and PPIE team. And along the bottom, we have the impact team. So the impact team includes implementation science. Our team is knowledge mobilization, communications, and improvement. And the reason the impact team exists really is to coordinate and enhance knowledge mobilization and impact activities across the Yorkshire and Humber Arc. So it facilitates collaboration between researchers, implementation scientists, communication specialists, and system partners to ensure that ARC research findings are effectively translated into practice and policy. I will now hand over to my colleague Juan, who's going to explore what we mean by evidence in health and care research and using evidence in ICBs.
Thanks, Nicola, and hi, everyone. So far, Nicola has covered why we're here, what the senior leadership across all 3 ICBs in the region identified as needs for knowledge mobilization when we interviewed them last year, what NIHR ARC is, its priorities, and its ways of working. For the next 10 to 15 minutes, I will take you on a journey through how we understand evidence, how we move from theory to action, and the potential relevance of all these 4 ICBs. After that, Tammy will go into more depth to explore how mobilizing evidence can address some of the ICB's priorities, including population health, neighborhood health, and strategic commissioning. So let me start by sharing a personal story that my partner encountered very recently in the NHS, and she said she was happy for me to share it. So next slide, I have it there. Yeah, no, the previous one. That's divine, sorry. Yeah, that one. I couldn't see it on my screen now. So November 2024, it was cold, unlike this week. My partner is feeling a lot of pain and decides to call the GP. So the receptionist answers and asks how long has she been experiencing this pain. She answers, well, for almost a week. Are you having your period? The receptionist asked, well, yes, but I know my body and this is different. So without asking for further details, the receptionist told her to call again next week if the pain persisted. And guess what? It persisted. So 5 days later, she calls again to eventually get an appointment for the same day. The GP, a male doctor, asked a couple of questions and then told her, yes, the male doctor, that pain and bleeding are very common when you're on your period. My partner, by then 37 years old, tried to explain that she knew her body and that it was not normal. Long story short, she was sent back home, told to continue with her regular activities and get some paracetamol. A week later, now it's almost 15 days of pain, she calls again, eventually gets an appointment, a female doctor this time. She listens to my partner, asks how she's feeling, empathizes with her, and acknowledges that she knows her body and that something is not right. Next step, she's offered a pregnancy test. She is pregnant, and most probably it is an ectopic pregnancy. 2 days later, she goes into surgery. It is an ectopic pregnancy. Her left tube is removed. A few more tests were run over the following weeks. Happily, things go well, and eventually she recovers. Why am I sharing this experience? Next slide, Divine, please. Well, I'm sharing this experience because evidence is information that can help us understand problems, inform decisions, and consequently improve the health and care sector. Evidence can help explain what works, for whom, in what context, why, and how it can be implemented. Now, evidence becomes useful through relationships, through trust, dialogue, and shared interpretation. It does not move into practice automatically, no? And I'll cover this in the next few slides. What counts as relevant or credible will depend on context, priorities, pressures, professional judgment, as I just shared with you, lived experience, as my partner, for example, local data, and organizational realities. What's the key point here? Is that evidence becomes useful through relationships, through trust, and through shared interpretations. Now, next slide, Divine, please. So let me share another experience with you. And this time it's after a conversation with Amy, my personal trainer at the gym. And we were discussing these healthy habits of food, exercise, sort of things you would discuss with your personal trainer. She was explaining to me why the evidence in her domain, and I think this applies to all domains for sure, is not enough. She said, you know what, Juan? Most people don't have an information problem. They have an implementation problem. People listen to podcasts, watch reels, save recipes, download plans, they follow influencers. And well, you can see from the tone of this conversation that she's younger than me and probably targets a much younger generation, but that's not the point. The point is that knowing and doing are two completely different things. She said, so yeah, I'll start my diet on Monday, I'll be better tomorrow. Then by lunchtime the following day, the person is eating biscuits and the cycle repeats. Now, excitement, motivation, perfection, failure, guilt, and then restart. This idea of wellness as a punishment or an extra for the to-do list, And again, the key point of this story being that evidence is not enough if we don't do anything about it, And you will say, yeah, we know that. We don't need someone to state the obvious, but bear with me. Divine, the next slide, please. So knowledge mobilization or evidence is about translation, is about exchange, this idea of sense making and collective learning I said before, and the implementation, not just dissemination. So as Amy, her personal trainer, said, most people don't have an information problem, they have an implementation problem. So evidence production in the end is shaped by researchers, practitioners, community funders, and decision makers. Ideally, with co-production helping make evidence more relevant and usable. You need to ask the patients, as we would live on. You need to hear what they have to say and what they know, because believe it or not, they're the experts too. With all due respect, the male doctor who discharged my partner in less than 2.5 minutes of consultation would have been way more helpful if he had at least considered what my partner had to say about her own body. So evidence has influence when diverse knowledge is valued, when findings are rigorous, timely, trusted, accessible, and connected to real decisions. Success would look like trusted evidence influencing choices people actually make. Next slide, Divine, please. So overall, strategic evidence is about moving research into active use by making knowledge accessible, relevant, and useful while bridging research practice gaps, creating demand for evidence, involving stakeholders through co-production, and building networks and partnerships for impact, as will be covered in the next few slides. Impact in this context, and I know impact is the buzzword for many organizations, impact can be understood in many different ways here. So it could be shaping policies and systems, supporting changes in service delivery, strengthening workforce capacity and skills, improving performance, generating economic or efficiency benefits, this idea of saving cost. Now, the value of evidence in the end lies in knowing which skills to use, when, and where, because the process is often relational, very context specific, and as Nicola very well said, messy. And here I'm talking about messiness, as Nicola said at the very beginning, not Messi, the World Cup top scorer. No, it's messy. What we do in knowledge mobilization, in mobilizing evidence, is messy. And we embrace messiness and we work on this context. Next slide, Divine, please. Very quick note on impact. As I mentioned before, I'm going back to ARC and NIHR, where Nicola started the presentation. The NIHR impact framework is centered around 4 key principles, impact being one, inclusion, innovation, and investment, these 4 I's. Now, these principles drive the NIHR research and funding decisions, aiming to improve health outcomes and ensure that research is accessible to all. What is key here to understand, and there are some examples of impact, as I mentioned before, the key is that the measure is not the activity, it is change, how we use evidence to improve decisions, services, and lives. Now, we've mentioned messiness a couple of times. The next slide is a big, big mess. Can you, next slide, Divine? We could have spent 45 minutes or the whole of this session just explaining this knowledge to action framework, which I'm not going to do. But we will be sharing these slides and you will have access to the recording, of course. Now, the idea of this knowledge to action framework is that it is a cycle that is a structured framework that guides the translation of research evidence into practical application, through knowledge creation and a 7-phase action cycle. I'm sure if I share this, well, probably not, but if I share this with my personal trainer, and me would be proud, and she will say, yes, that's what I was saying. It's not a matter of information, it's about implementation. So how we move in this cycle, considering a number of things, and evaluating, making it sustainable, adapting to the context, identifying the problem and identifying the gaps that exist there. So, as I said, we will be sharing these slides, and the presentation will be, it is being recorded, so you can go back to this, or if you have any questions after the session, feel free to ask. So next slide, please, Divine. So now we will discuss how all these ideas of evidence that I have just shared with you, what we understand by evidence, how we can implement it, why it's important to do it. Now, why any of this is useful or helpful, specifically in the context of ICBs. So first I will try to set the context, and then as promised, Tammy will cover a number of priority areas in more depth. Next slide, please, Divine. So, using evidence, research, and other types of knowledge, we want to believe, or we choose to believe, that helps in a number of different ways and can help the ICBs in a number of different ways that you can see there in terms of population health, commissioning a value. Oh, what happened with the slides? No, before. No, there, thanks. As I was saying, using evidence, research, and other types of knowledge can improve a number of things, and that's what we want to believe. It can improve population health outcomes. It can support better use of NHS resources. It can address health inequalities, reduce risk in decision-making, hopefully, support innovation and adoption of best practices, and ideally align with national NHS and local ICB priorities. That's why we are here. Bottom line being that better evidence use, I would say, supports integration, transformation, and continuous improvement. That's something we aim to do too by knowledge mobilization, mobilizing evidence. Now, next slide, Divine. I think this is my last one before I hand over to Tammy. So ideally, and again, this is an ideal diagram and how we see this pull and push exercise or collaborative process. We have, in this case, an NIHR and we have ICB. So NIHR will say, this is what we can offer. And ICB will say, this is what we need. So ideally, we'll try to align both in this continuous and changing and repeating process. No? So researchers, in this case, ARC, will proactively share relevant evidence, insights, and knowledge, will try to translate into accessible, decision-ready formats. Emerging findings will be communicated to inform strategic priorities. And ICBs, on the other hand, will try to identify those needs, priorities, and challenges, will make decisions seeking research to inform that commissioning, as Tammy will cover, and will question their questions from practice will shape future research activity and evidence synthesis. As I said, the idea is working together. No, the whole point of this presentation and trying to connect ARC with ICBs is working together. These ongoing relationships, dialogue, and co-production, researchers gaining a better understanding of strategic and operational context now in the ICB, and ICBs gaining timely, hopefully relevant evidence that is more likely to influence decisions and ultimately improve outcomes. That said, I'll hand over to Tammy that will go in more depth on
Thanks, Juan.
all this.
Next slide. Thanks, Divine. Next slide, please. So if we outline the definition of what strategic commissioning actually is, the NHS Confederation defines as a continuous evidence-based process to plan, purchase, monitor and evaluate service over the longer term with the aim of improving population health, but reducing inequalities and delivering high quality, equitable care. But I suppose the question is, how do we continuously embed evidence in that planning cycle at every stage? So we recognise, the recognition of ICBs take on a greater responsibility for population health. The ability to work with evidence isn't just a technical skill, it's a strategic capability. And what we mean by evidence here is broad. It includes published research and evaluation findings, yes, but also routine data and intelligence, the professional expertise of clinicians and practitioners, and the lived experience of people who use these services. But the challenge is that these different knowledge types don't always speak to each other. There's a recognition, even with, from an academic point of view, and from practice, in the fact that research may sit in journals, local data may sit in systems, community insight may sit in consultation reports that never quite make it into commissioning conversation. And the challenge is bringing this all together at the right moment, in the right form, for the right decisions. So across the commissioning cycle, there are distinct evidence demands to identify what's known, critically interpret what it means for their context, apply it to the decisions in front of them, and increasingly generate new evidence where gaps exist or where local learning needs to be systematically captured. Next slide, please, Divine. So if we accept that strategic commissioning needs to be evidence-based, the question becomes, what does it actually take to make that happen in practice? And we've been thinking about this across 4 areas. So the first is about infrastructure. So having the right foundations in place. So looking at shared data, shared platforms, agreed ways of working. And without that, evidence tends to live in silos and never quite reaches the people who need it. The second is capacity and capability, and making sure that people across the system have the skills and confidence to engage with the evidence and not just the specialists. This isn't just about analysis, it's about commissioners, planners and leaders feeling really equipped to ask good questions and interrogate what they're being shown. The third is embedding evidence into process. So making it a routine part of how commissioning decisions get made and not something bolted on. And that means creating the right touch points in the commissioning cycle where evidence is expected, really valued within that process and used. And finally, is integral to what Juan was also talking about that partnership, is that co-production. So designing the evidence relationship together rather than research being done to commissioners. When ICBs and ARC are genuinely working as partners from the start, the questions being asked are the ones that actually matter for local decisions. But none of these 4 things will work in isolation. They reinforce each other, and that's really what a strengthened partnership looks like in practice. Next slide, please, Divine. Next slide, please. We've already talked about knowledge mobilisation as a 2-way process. and not simply pushing research into the system, but creating a dialogue between evidence and the actions that the system is trying to solve. Population health is where that relationship becomes most powerful, because the challenges are complex, the inequalities are often stark, and the opportunities for prevention are really significant. At its best, though, this process turns data into actionable insight. So it helps us move beyond describing what's happening in a population to understanding why it's happening, who is most affected, and where can we intervene most effectively. And that's the difference between reacting to demand and proactively improving health outcomes. By combining population health data with research evidence, we can identify high-risk cohorts and underserved communities with much greater precision, and we can understand the specific barriers, needs, and circumstances that shape people's health, allowing us to target interventions where they can actually have the greatest impact rather than relying on a broad brush approach. And we know that that's a real focus in terms of that population health focus. So research also helps us understand the wider determinants of health. So how housing, employment, education, social connection, and the factors that sit behind traditional health services, but often have the greatest influence on outcomes. Just as importantly, it helps us understand what interventions are most likely to make a difference. Next slide, please, Divine. I do apologise. I don't know why the slide's gone a little bit funny like that, but it's not meant to be like that. So part of that is that we're looking at strategic focus, which identifies priority population, places and pathways where evidence can make the greatest difference. Impact measurements are measures if mobilised knowledge works through outcomes, inequalities, indicators and patient experience. But evidence alone doesn't create change, and knowledge mobilisation plays a really critical role in connecting the people who need to act on that evidence. But bringing together analysis, commissioners, clinicians, providers and communities and patients around a really shared understanding of both the challenge but also the opportunities. And when those conversations happen well, evidence becomes more than information. It becomes a strategic tool for prioritization and a system connectivity, targeting resources, measuring impact, and driving prevention-focused commissioning. Ultimately, population health is not just about understanding needs, it's about using evidence to connect the system around action, ensuring that insights leads to decisions, decisions lead to interventions, and ultimately, interventions lead to better outcomes for the communities that need them most. Next slide, please, Divine. And again. Thank you. So within this slide, it's about how evidence strengthens integrated neighbourhood teams. There's just been some formatting problems there, so I do apologise. I think that's the icon. So, if with a 10-year health plan, the shift to neighbourhood, this requires evidence base that doesn't exist in a format for scale and adoption. We know that the challenge around evidence gaps. So, ICBs must commission, develop and evaluate new integrated models with really limited precedent, some inconsistent data, sharing models, data in itself. Oh, sorry, Divine. We'll just wait a second. Thank you. Yeah, next slide. Next slide. Next slide. Perfect. Thank you. And no shared framework for really what good looks like. And also bridging evidence and practice. So knowledge mobilisation translates emerging evidence into practical decision-ready insights, and that really co-produced with system partners. Next slide, please, Divine. So with this slide, it's how evidence supports ICB commissioning decisions in integrated neighbourhood health. So really, let me bring this to life. Let me bring this to life with a worked example. So we want to develop integrated neighbourhood health teams, and the starting point is understanding local need, pulling together population data, health inequalities intelligence, service utilisation patterns. But the question is what does the picture actually tell us about this neighbourhood? Then comes the questions, what does the evidence say about what works? And this is where ARC would add immediate value around rapid evidence synthesis, drawing on existing research and combining it with a local data analysis. Crucially, the evidence on integrated neighbourhood models isn't always clear-cut, and the literature is really mixed. The models vary from different demographics, even across the 3 ICBs, and context matters enormously. So the questions become, what model best fits our population, our system, and is actually sustainable here? That's where co-production and co-design become essential, working with the clinicians, providers and communities to turn evidence into real choices, and not just adopting a model off the shelf, but adapting it. And that's an honest process, and it takes time to do that really well. But once a direction is agreed, commissioning decisions follow, and with outcomes and experience measures built in from the start. Then as the model embeds in, evidence on what's working, from who, and in which conditions start to emerge. So economic evaluation sits alongside that, and critically insights are shared across neighbourhoods. So the system learns collectively and not in pockets and silos. And finally, the evidence base informs how you scale and how you adjust commissioning strategy, and how local learning feeds into that national conversation. Next slide, please, Divine. So from identifying an evidence gap to decision making, we just wanted to briefly touch on without the use of evidence. We know neighbourhood health team models commissioned on policy intent and not evidence. Evaluation left to chance or not done at all. Data held in silos across GP, acute and social care, but learning stays local, no system-wide intelligence, and inequality risks going undetected until too late. But with the use of evidence, its evidence synthesis really informs that neighbourhood health team design before the launch. Evaluation, logic model, co-design with ARC from day one. We've got really linked data analysis, identifies need and tracks outcomes, but that shared learning infrastructure connects neighbourhood teams. But the equity lens built into evaluation and service monitoring. So where could ARC support ICBs? And it's which neighbourhood health team questions matter today? Where is the biggest evidence gap in your system? But really, what does good integrated care look like in neighbourhood health teams? Next slide, please. Fine. So if there's one thing I'd like you to take away from today, it's that evidence-informed commissioning isn't about producing the reports, more reports. It's about creating a system that learns through knowledge exchange. When we think about integrated neighbourhood health, we often focus on the services that we really want to build, but the real opportunity is to build a way of working that continuously learns from people and communities we serve. And it starts with understanding our population, not just looking at data, but using it to see where needs are greatest, where inequalities persist, and where people are still falling through the gaps. From there, we bring together the best available evidence, not evidence for its own sake, but evidence that helps shape, answer practical questions. So what has worked elsewhere? What should we adapt? What should we do differently? We then use that evidence to shape services from the beginning. So working with partners collectively, professionals and communities to design neighbourhood models that are grounded in both evidence and local reality. And I think that's really key. And because these are complex system changes, evaluations isn't simply about proving success. It's about understanding what is making a difference, for whom and why, so that we can improve as we go. Most importantly, we create that feedback loop. So learning from delivery feeds directly back into commissioning decisions, helping neighbourhood teams evolve, adapt and become more effective over time. Because ultimately the goal isn't just to generate evidence. The goal is better decisions, better services and better outcomes for people and communities we serve. And that's where ARC and strategic evidence partners can add real value in helping turn evidence into action and action into lasting improvement. Next slide, please, Divine. Next slide, please. So bringing it back to where we started in today's session, so slides 2 and 3, we talked about the work we did last year to understand the ICB's needs around knowledge mobilisation and aiming to address some of these in today's session. We now want to continue this cycle of engaging with system partners and with the ICB to further understand the needs and develop our approach and offer in collaboration with you. So these are some of the areas of our support offer. So alongside knowledge management, capacity building and training, engagement and co-production. But we've also have next steps. So from September, we have a webinar series that's focusing on the modern service framework, and also the proposal of ICB needs-led knowledge mobilisation training. Next slide, please, Divine. And that's the end of the Lunch and Learn. So thank you for joining today's session. These are our contact details. We also have a knowledge mobilisation and communication leads, Kate Robinson, and then we will open up to questions.
Thank you so much, Tammy, Juan, and Nicola. So if anyone have a question, please put it in the chat or raise your hand and we can unmute you.
No question?
Hello.
Oh yeah, use the chat. Hi. Hello. Did someone just tell us?
It is. Sorry, it's Jake. I'm struggling to find the hand raise on Zoom, which is quite embarrassing, isn't it? There we go.
Oh no, it's easily done. Don't worry. Hi, Jake.
Yeah. Hiya. Just a quick question about the program overall. Just thinking about the links with the strategic commissioning development program that's just being launched at the moment. There's I think the two things can dovetail really well, but there's going to be a lot of comms coming out through ICBs around how they develop core competencies for strategic commissioning, and within there, as you'd expect, there's quite a big focus on intelligence, evidence, decision support, those kinds of areas. So it would be worth that alignment against competencies and a conversation with some of the providers of that national programme, possibly through the ARCS network as well.
Yeah. Okay, brilliant. You work closely with Juan, is that right?
I do, yeah.
Yeah, brilliant. Okay, then we can definitely bring that in, because I think there are some really key opportunities. So yeah, thanks Jake for sharing that. I think Louise, is it Louise? Have you got your hand up? I can't really see very much actually, but I think I've just seen.
Here's Louise. Come in, Louise.
Yeah. Yes, hi, Louise.
Sorry. Hi. Jake, I managed to find the hand eventually, so I beat you, but I can't figure out how to turn my camera on, so sorry, it's just my voice. So I work in Humber North Yorkshire ICB, and you may have kind of touched on this already and I missed it at the beginning, but I suppose what I'm wondering, and it might be Jake that I need to ask the question to potentially in our ICB, but where are the current touch points with knowledge mobilisation colleagues in ICBs, and how does the kind of the insights, the local insights from our current places, or soon to be neighbourhoods, get to yourselves? So, and is there like a kind of a sort of structure, organisation kind of diagram that can help me see how that sort of links? And so I'm thinking about kind of from the nursing quality team, for example, how do those things sort of go up to yourselves and then back down to us? Does that make sense?
Yeah, absolutely. I think you've raised something really key there, because that's something that I think would be a great within our roles, like the strategic evidence partner role, to establish what that would look like between the ICBs and the ARC. And I think with what you were talking about there, we have obviously the Applied Research Collaborative, but under BIHR we've got the Patient Safety Research Collab as well that would fit into a lot of that. So and I think it's that wider network. But from our point of view, from me and Juan, please jump in. So I know Louise will be working with you closely, but we would want to make that as streamlined as possible for the teams, so to make that really clear. So that could be something that we could take away from today, and really have a focus on to ensure that that's that process is really in place.
Thank you.
Yeah, so we'll definitely follow that up, Louise.
Thanks.
Jake, is that a
hand?
You managed, yeah.
Yeah, it is. And hi Louise as well. I was just going to respond on that one specifically. So in our context in Humber and North Yorkshire, we've just quite formative at the moment and thinking about how the architecture is going to work and how our ICB model is going to play out. So if we've got designed around programs of care, and Juan and I have been talking about this quite a bit locally. What we've said this morning is with our directors is that we'll be looking to have a critical part of all of this is that we have a process of generating cross-cutting insights that brings together what's coming out of the conversations we're having as a strategic commissioner around performance and quality and finance and outcomes, and we're able to surface those in the round and be able to share them and to share them up with our board, but actually to have one in the room so that we're surfacing things that will be around the interface with ARC and with others. And there's a two-way flow there. So some of it's about what's coming up from the system, what are the priorities, what are the asks, what are the risks, but also what's coming out from ARC, what's coming out from the modern service frameworks, what's been published this month. And whilst I agree that one's point around implementation gap being one of the biggest thing, I think there is still an information gap in terms of curation of information and knowledge. So there's so much information out there, but I think there's a really critical role in being able to really actively support ICB staff in ensuring they have the right relevant evidence at their fingertips to support decision making.
Yeah.
And that's a two-way process that we're generating and harnessing the right evidence, but also making people aware of the vast amount of stuff that's out there in a really targeted way. But it's all still coming together. But I would say this because we have an advocate for knowledge mobilisation. We're just keen that it gets absolutely embedded in the architecture for the ICB as it stood up. Very positive response from our execs and board on that so far.
Yeah, that's brilliant. One of the things that we are... Oh, sorry, why can't you go?
Yeah, and I just want to add that this is just another example of how we want this to happen in this two-way relationship that Jake was just suggesting. Now we want to build on the ICB needs and see where can we help and set those processes. We are being very conscious of the context that ICBs are going through. This last year and a half. So when the new world happens in the new structure, we would like to be there and being that point of contact that Luis was asking for and helping in the best way we can. Now, understanding that there's lots to offer, there's lots of information out there, as you said, Jake, and hopefully we can strengthen and continue building this relationship between ICBs and ARC. Sorry, Tammy.
No. I was just going to touch on the fact that in relation to that, Jake, one of the things that we've pulled together is it was a targeted program. So we've looked at Embed I&H, which is evidence and mobilisation for integrated neighbourhood health, and that's exactly that. There's a lot of historic evidence really that's been developed that's sat there, but also what is currently being generated, and how can we make that into a program so it's, like you say, it's targeted and connect the research that's relevant to that program that the ICBs really need. Another one that we're exploring, one of our KM activities that we're just starting to get up and running, is palliative care, and that looks cross-functioning with the two modern service framework at the moment with palliative care and frailty, but thinking about that integration and that integrated model of care. But how do we, like you say, have that as a program or a package for ICB colleagues to be able to tap into, because it aligns to the priorities. So that's something that we have just started to establish. So we can absolutely cascade and share that with you, just just to ensure as well that we are getting that right, because I feel that that's something for us as partners. We want to ensure that from our presentation, even the language when the initial interviews was carried out with leaders at the beginning with ICBs, and that's why we changed our title, because we want to ensure that that connection is there, and often it is aligning that. So it's just to add on that, and just work with you to kind of know what those priorities are and bring that through.
And I think I can't find the raise my hand button, so I'm just going to jump in. I've struggled as well, Jake. I think just to add to that as well, it's understanding, as you mentioned, Jake, what the kind of preferred formats are for us providing you with the evidence. So we could easily kind of just send you a load of research reports and papers, but it's understanding from a ICB perspective what are the key bits of that you need, and can it be within our role to kind of draw those bits out so that you're not having to kind of go through lengthy research papers to find the key bits that are of interest to you.
Perfect. I can see your thumbs up now, Jake. I think you've got that button. It's really tricky to find it on Zoom though, even trying to move your screen. So does anyone have any other questions? You can just speak up. Don't worry if you can't find the hands up. No? Okay, well, this is recorded, so you were able to get access to it. As we've left our contact details as well, please do reach out to us if there's, and obviously we're in reaching as well to teams, but we've taken away some of those points as well, Jake and Louise, so thank you for contributing, and more to come as we've shared around the webinar series starting from September. We've got a date of the 14th of September for frailty, and then the 24th of September for focus on children's, and then we'll share more around the KM activity that we have around embed INH, and also the palliative care one as well. But yeah, brilliant. Okay, well, thank you for joining today. I'll hand you over to Divine. Divine, I'll let you do.
Well, thank you so much. Yeah, we'll send all the link for the recording, and also like all the information for the upcoming webinars. We'll send it around to you guys as well. So thank you for joining us, and thank you, Tammy, Nicola, and Man, for a lovely presentation.
Brilliant. Thanks, Divine.
Thanks, everyone.
Thank you, everyone.
See you soon.
Bye.
Bye.